Welcome back to AME's facilitated session. So now we are in our third segment. So segment 3, because we all know what you want. We know what the scholars want.
They want to do the practice questions for step 1, step 2, and step 3.
Exactly.
Let's go through the practice questions.
So just to recap, the first section, we focused on the focus. How do the student scholars focus their study dedicated time period on? The second segment that we talked about was the format. So this was how the exam and how the test questions are formatted between step 1, step 2, and step 3. So this third segment, we're focusing on the execution, right? And we're going to do this in a practical style. So we're going to use actual exam questions and just give us a little bit of information about how we're going to organize this particular segment.
Excellent. So as you said, again, as a reminder, the focus is the focus of each segment of the exam, where step 1, focusing primarily on mechanism, pathophysiology, step 2, CK, diagnosis, and next step in management. Step 3, focused on now extended management of the patient and some very complex diagnoses. And with that focus, appreciating the difference in the format of the questions that address that particular biomedical science and clinical science content. And we talked about those different formats, which we'll see in a moment. And when we can do that with those two, the right focus and understanding the format, you can execute a strategy to engage these questions. And so in this segment, we're going to take one key biomedical or clinical science concept. And with that one very common concept that you will see on your exams in medical school and across your licensure, we are going to complete a step 1 question, look at the focus and the format of that and how to execute it. Then we're going to adapt that step 1 question, which is actually a retired question from the National Board of Medical Examiners. So it's an actual step 1 question that's been given by the National Board of Medical Examiners. We'll do that first. Then we're going to adapt that question for step 2 CK context and see how the focus changes, how the format may change, and how you must execute accordingly. Then we're going to adapt it again for step 3, and we have to adapt it twice because we have to look at it in the context of fundamentals of independent practice and advanced clinical medicine. So one concept from 4 perspectives across the USMLE series. Remember that step 3 has 2 different sub areas, FIP and ACM. That's what we're going to be doing. And of course, I have the expert physician who will be answering the questions, because what do I know about medicine? Dr. Jackson has the MD, and you aspiring physicians are going to have your MD soon. And some of our outstanding residents who are watching, you have your MD. So we're going to need all your help to participate.
Right, because when you said we, I was like, you mean we, me?
That's right.
Like,
who is the we?
Right, who's the we? And when did we start speaking French? You know,
exactly.
So we. Let's jump into this.
So in our first series, just to look at the core concept, clinical science concept we're going to be evaluating is dysmenorrhea. Dysmenorrhea, very common, and we're going to look at that across step 1, step 2 CK, and step 3. So let's look at the USMLE Step 1 question. This again is the retired National Board of Medical Exams question for step 1 on dysmenorrhea. Dr. Jackson, why don't you read the vignette for us?
All right, I'm in the hot seat. All right. So a 25-year-old woman comes to the physician because of a long history of pain with menses. The pain occurs on the first day of her 5-day menstrual period and lasts all day. She rates the pain as 10 on a 10-point scale. The most appropriate initial pharmacotherapy to relieve this patient's pain has which of the following mechanisms of action?
This is already exciting. Do you see any key information in the vignette or the question that alerts you to, in fact, this is a step 1 question? Even though we told you from the initial outset, is there any key information in the vignette or the question, not the options, that alerts you this is a step one question?
So, as we say in the fraternity, key word,
Exactly.
mechanism.
Mechanism.
Mechanism of action is right there in that
Mechanism of
qualifier.
action. So notice they said initial pharmacotherapy, and as we have emphasized before, the actual drug to treat the patient is step 2 CK or step 3. However, if we say pharmacotherapy on step 1, we will always ask you the mechanism of action because step 1 looks at, from pharmacology point of view, pharmacokinetics and pharmacodynamics. And that's exactly what they're asking. Now, before we can even think about, well, what would be the drug? So we would then think about the mechanism of action of that drug. What do we need to know?
We need to know the mechanism of the physiology, the pathophysiology, what's going on. Well, we said dysmenorrhea. We already
Well, that's right. We said that. So that was a good hint.
Scholars
wasn't
know
it?
that.
The scholars know that,
But
right?
if I was just to read the question, I would need to first assess that this patient is having, that this is a dysmenorrhea context.
That is correct. And what are the indicators that this is potentially dysmenorrhea?
The pain with menses, the time frame in terms of the 5-day menstrual period and last all day. There seems to be, like I said, the 10 out of on a 10-point scale. So there's a very brief, they're giving you brief clinical cues to let you know that this is a dysmenorrhea context.
That's right. And sometimes, as we said in step 1, they could just say, what is the diagnosis?
Right.
And you could say dysmenorrhea. But most of the times they either tell you the diagnosis directly or they will give you the information that leads to a diagnosis and they ask you a different question that goes back to mechanisms of action, the pathophysiology or the mechanisms of action for pharmacology. So what drug or drugs are used to treat dysmenorrhea?
Well, if you're looking at the algorithm, first you want to start with the NSAID.
Okay. What is an NSAID? Because I'm not a doctor. I just play one on TV.
A non-steroidal anti-inflammatory.
All right.
So you're going to that because the basic pathophysiology of the dysmenorrhea is increased prostaglandin, which is causing that increased contractions or increased uterine just pain. So that this is where the dysmenorrhea is coming from because you have increased prostaglandins that is happening, which then causes the pain. So the NSAIDs is what's, the mechanism of action within the NSAID, which is a cyclooxygenase inhibitor, COX inhibitor. That's what then cuts down those prostaglandins, which then provides relief to the patient, or should provide.
I see. Okay. And so notice that again, they did not list in the options any drugs. They list the mechanism of action, right?
Right.
So we're therefore looking for the mechanism of action or something that relates to, in essence, blocking prostaglandin synthesis.
Right.
And do we see that here anywhere?
We see C, inhibition of prostaglandin synthesis.
Isn't that interesting? It is right there. So that's not very difficult. Sometimes it can be what I call a directed response question. But this is a good key that, you know how we always say, yes, there is core knowledge you need to know. There's also thinking and testing skill that we may need to have. Here, the thinking skill is really assessing what is the patient's condition so you can move to the drug.
Right.
And then once you know what that is, it depends on whether they have any other options that are similar to prostaglandin synthesis. Are there any other options here similar to prostaglandin synthesis?
Nope.
Nope. They're all in a different domain, right?
All in different domains.
That's right. They're all in the sort of reproductive endocrinology domain that we can see there, right? Those pathways. And so therefore, this is a question that we can easily and efficiently select C. And do you believe you are correct? Because I always got to ask you your confidence level on that.
Oh, 100% correct.
Are you 100% confident on that?
Yes.
All right. Well, you are correct. And I'm sure our audience also selected C, so you're both correct. So this is a classic step one question. Let's think through now, Dr. Jackson, how would this question be adapted for a step 2 CK context? What would the test question writer do?
So for step 2, you want to assess the clinical skills. So at that particular point, going back to our format and foundations conversation, we're looking at supervised management. So what would be the next step of management when it comes to managing this patient with dysmenorrhea?
So next step in management, how we manage it, but they could also just ask you the diagnosis, right?
They could do that.
All right. Now, you said earlier, because we're anticipating two pieces, and this is how we have to think. As we're practicing and getting ready to practice questions, you can become a test question predictor in understanding how the exam is focused. Now, step 2, CK, what's the focus? It's diagnosis and next step in management, and in understanding the potential question format that will be coming up. Now, you mentioned earlier that the underlying pathogenesis to dysmenorrhea was, in essence, there was this prostaglandin, like excess prostaglandin synthesis and release. And prostaglandins cause uterine contraction. There can be some associated ischemia with that because there's so much contraction going on, and that's causing pain, right? And by inhibiting the amount of prostaglandins secreted, then you decrease that type of activity. So again, if it was step 1, they could just ask us, what is the mechanism of disease? Now, it's helpful to know the mechanism of disease because, again, going to step 2 CK, if we're looking at management, we may look at a pharmacotherapy that actually does that.
Right.
Interesting, right? Now, the diagnosis would simply be the diagnosis. The underlying pathophysiology is not going to help us. It's just you have to know that this is what we call it as a result of that pathogenic process. So this is where I'm going to see how this is going to be set up. Are you ready to go to the adaptation?
Yes.
So we can see what it would look like now.
Adaptation.
So we're going to take that first question and adapt it for step 2 CK. And let's see how that works out. Go ahead and read the vignette for us.
Okay. So a 25-year-old woman comes to the physician because of a long history of crampy pelvic pain during her menses. All right. That already gives us a little bit more information.
Oh, let's stop right there. Because we see that there is more clinical sequelae, if you will, being added to the vignette. We didn't get this history of crampy pelvic pain. We did get, she's having some pain, but now it's more descriptive.
Right.
Interesting. Okay, continue.
So the pain consistently begins on the first day of her 5-day menstrual period and lasts for 24 hours.
That was the same as the previous vignette.
She rates the pain as 10 on a 10-point scale and notes that it occasionally is associated with nausea.
Similar to the previous vignette, but what did they add to that sentence? Nausea. Additional sequelae.
Right.
Interesting.
She is sexually active and uses condoms for contraception. Physical examinations include a pelvic exam, shows no abnormalities. Which of the following is the most appropriate next step in management?
Now, was the sexually active and uses condoms for contraception, was that in the previous vignette?
It wasn't, but it's very important.
And why is that here?
It's here because, in a way, it's serving as a distractor to give the student some information about a potential for pelvic inflammatory disease.
Some other condition that could also be the source of the pain.
Also, yeah.
Isn't this interesting? So step 2 CK now requires us to process more clinically related information to determine a more specific diagnosis from possible diagnoses or differentials.
Right. Because what I would be looking for there, and I guess I'm going to assume that it's consistent condom use because it doesn't say consistent versus inconsistent condom use.
Correct.
Because it could say inconsistent condom use, and then that moves a potential pelvic inflammatory disease a little bit further up on your differential. I mean, given the fact that you have more stuff.
You just hit on another important point, because a lot of times scholars will say, well, was it consistent or not consistent? In order for us to move up the context of a sexually transmitted disease, there has to be specificity. When we practice questions in advance and do this type of analysis, we see the pattern of how a question is going to be asked, so we're not second guessing ourselves on the actual test day as to what is being indicated or intimated by the information provided.
Right. So another thing is the pelvic exam. So that was more information from the previous, because then that gives you, there was something done in this algorithmic step of management already. They did a pelvic exam. So it's saying that the pelvic exam showed no abnormalities. The fact that the previous sentence did not specify whether or not this condom use was consistent or inconsistent. So I'm going to assume that it was consistent condom use because it says condoms for contraception. And then it makes me feel even more confident with coming to that resolution on the condom use, because it then says physical examination, including a pelvic exam, shows no abnormalities. So if we was thinking about a pelvic inflammatory disease process, we might think about discharge in accompany to the pain, other type of symptoms, maybe fever, different quadrant pains that can relate to a infection in the genital urinary tract.
So let me stop you there. What you are doing now is you're slowing this process down for our scholars, but all of this is happening within seconds.
Light speed.
It's synthesis of basic science information, which is back from step one, and all the different pathogenic mechanisms that could be working here, and rapidly, based on the presentation and additional key contextual clues that move in a particular direction, just as if you were in clinic right now with a patient.
Right.
That's how focused the test question writers must be to guide you to where they want to go. That's why this is not an academic haze. This is assessing your skill to do exactly what you just did. Isn't that interesting? To rule out pelvic inflammatory disease and now stay with the consideration of likely dysmenorrhea. Now watch this. Read the question.
Which of the following is the most appropriate next step in management?
There's something interesting about that question. Tell me what it is.
It's asking, what do we do next? What's the next best step?
Which is part of the focus of step 2 CK. What is the next step in management? And then there are two qualifiers. Is that correct?
Yeah.
What are they? This most appropriate.
Most appropriate, yeah.
Most appropriate, and then we know the next is already there. So why did they say most appropriate?
Because there's things in these answer choices that could be within the algorithm of working up dysmenorrhea.
But they're not
the next best appropriate.
Exactly. Choice. They're not the most appropriate next action step to do.
Given the
Do you see again the subtlety of understanding the format of the question and processing the information you understand and knowing the clinical algorithm? You have to make decisions, okay, what has been done and therefore what is most appropriate to do next.
Right.
This is getting very interesting. Right, we just went from a step one focus of, oh, let's just do the mechanisms of action of the drug because it's dysmenorrhea, to now having to make sure it is dysmenorrhea. And now that we've done that, we've moved out pelvic inflammatory disease, we have to know the clinical algorithm. Right. Advanced information now for the next level of the USMLE series. This is getting exciting.
Right. So
Okay, let's go through the options.
Let's read through the options. So option A, laparoscopy. Option B, medroxyprogesterone acetate. Option C, naproxen. Option D, combined oral contraceptive pills. And option E, pelvic ultrasound.
Let me ask you, are all of these possible things we could do, or is there something that we should eliminate that either has already been done or we would never do?
I mean, most of these things fit within the workup of some type of dysmenorrhea clinical context. Again, the additional information changes things because right here in the vignette, it says that the physical exam, including a pelvic exam, shows no abnormalities. Now, if that pelvic exam showed some abnormalities, then something else might be activated on this list compared
Such
to
as
something.
what?
Well, then maybe we might need to do a ultrasound or a
Right.
laparoscopy.
All
Yeah.
right. So therefore, are you saying that A and E you might eliminate because the examination hasn't revealed any abnormalities? Or are you saying that I may need to consider doing one of them at some point because I couldn't see anything just from the examination?
I'm saying that
Yes.
I'm saying that based off of the information in the vignette, okay.
It's just like being back in the classroom with me, isn't it?
Based off of the
It's the national audience watching, no pressure.
based off of the information in the vignette, the fact that the patient does have a normal pelvic exam, we don't have much information about the status of this particular patient.
Okay.
You know, however, we're not looking at some type of peritonitis where we need to do some exploratory. We're not there, right? So that's the reason why, in terms of a laparoscopy and a pelvic ultrasound, those are more escalated procedures to do if we found something wrong with this particular context. But my thinking is
the
that
context is not warranting that, is what you're saying.
No, because dysmenorrhea is more like a clinical diagnosis. So once we have confirmed, and I would assume that we would have done a beta HCG, so we've done a pregnancy test, we would have ruled that out.
But that's not an option here either.
That's not an option.
Right.
And
so
I don't want to bring too much information out.
Right.
But
so that's a good piece to know to stay focused.
Right,
We're
to
going
stay
there, right?
focused.
To stay focused within the question with the options we have,
Right.
because what we just did there was use some cognitive energy that may not be needed
Exactly.
to use to exhaust. But what I do appreciate what you're saying, and that's why you were smiling at me, you're like, I'm not taking that bait. Options A and E are there because, as we said earlier, sometimes options are possible because they could be part of a workup. But based on what's been presented, they are not warranted, and in fact could be perceived, especially the laparoscopy,
As
to some
invasive.
extent, as invasive.
Right.
So it's not warranted. So when you think about the first line of intervention for dysmenorrhea, what is your treatment as a first line intervention?
An NSAID.
Oh, we're back to an NSAID again. I like to say,
Right.
is there an NSAID on this list?
Naproxen.
Well, look at that. They went from the step one question, how can we stop the process? What would be the pharmacotherapy to do that?
Via
And now I
mechanism
ask you
of
exactly what it
actions.
is. And that's most appropriate because right now we have enough information not to consider PID. And these other options are things, they may be possible, but would they be done? I see hormonal therapy here in option D.
Right.
That could be done later
Right.
as an option, but that's certainly not first line.
Right.
Interesting. What's your confidence level on that?
100%.
This is interesting. Are you sure? Because I'm kind of liking potentially another option. I think I can sway you for something else, or you want to stay with that?
Well, which one are you talking? I mean,
I don't know which one. I just like to throw things out because I'm the saboteur.
yeah. I mean, I'm sticking to C because it's
That's
saying
good
which
because you are
because
100%
yeah.
correct. I just want to have some fun with you as I always do. Now, this particular question, when we start looking at the pearls, as we like to say, we call them our AME pearls, where we deconstruct the question.
Right.
When we're looking at this question, we can clearly see the shift in the learning objective from step one, which looked at the underlying pathogenesis and a pharmacologic mechanism for the drug, to step 2 CK, which is you got to have a diagnosis,
Right.
and you have to know the next step in management. And the management here is first line is NSAID. So you see that shift.
Right.
Supporting that shift within the vignette, we also noted that the question format went to that most appropriate next step. That's key to the form or focus
Right.
of step 2 CK. How are we going to manage? We also see clearly that they've added some additional clinical nuance
Right.
by adding additional sequelae to move you now into that focal point of diagnosis and then what should be the next step. That's how we adapt the vignettes to move you to the next level in the USMLE series.
Right.
Now, so far, I believe Dr. Jackson's been using the USMLE series success playbook. I got to keep an eye on him because in understanding the focus,
Right.
right, the goal, and the format of step one and step two, you've been able to navigate this so far.
So far. I think I'm
Let's now adapt the question again from the original NBME step one question. Let's adapt it for step three. First for FIP, Fundamental Independent Practice, and then for Advanced Clinical Medicine. Now, before we do that, let's see if we still have the focus and the goal in mind, and even to some extent the format.
Right.
What would we expect this question, how would we expect it to be adapted for step three?
Step 3 can add a context of, so we could talk about like a comorbidity.
Okay.
So maybe this patient like has some type of clues in the vignette for a PCOS, maybe an undiagnosed polycystic ovarian syndrome. Uh, maybe how old? 25, a little bit older, but maybe, and this goes back to some of the things that was being assessed in the first original question. So when we talked about the 11 beta hydroxylase activity, that was B on question 1. So a congenital adrenal hyperplasia, so some things that fall within that dysmenorrhea context as a sequelae to something that's also there. So like I said, a PCOS, which then, you want to talk about an amenorrhea or dysmenorrhea context, clinical context, other type of hormonal hypogonadotrophic hypogonadisms context. Is there something else like that being added on? Is there some type of medication that this patient might be taking that might be causing a amenorrhea or dysmenorrhea context?
So this is very interesting because this is classic there for step three that moves toward more integrated, not only biomedical science, but clinical science that requires advanced thinking now to make decisions about what's going on. Sometimes they'll add different epidemiological components to it, or even some other advanced biomedical science, a lot of pathophys, but it's very complex because the patient has multiple things going on. So the complexity of the underlying pathophysiology you will see on step three could all of a sudden just become overwhelming. Like, what is going on? All right, that would be fundamental independent practice. If we move it now toward advanced clinical medicine, how do you think they would adapt it?
So advanced clinical medicine, now we're talking about a potential, this has been going on for a few months now. All right.
Longer-term management to
Longer-term
address an issue.
management, yeah.
What is happening? Unfortunately, we know that there are some patients who have concerns with dysmenorrhea over a period of time and other complications, etc. So the case is going to become more complex.
More complex.
There is more targeted management and longer-term follow-up, which is a key component of advanced clinical medicine for step 3. Interesting. And sometimes as we're investigating what might be the underlying reason for the irregular menses or lack of menses, your information gathering from other sources that's happening with the patient, there's other information that is being synthesized. It's almost being an advanced medical detective. That's also part of the step 3 advanced clinical medicine goal and focus, which is to have you synthesize different sources of information that are being presented as part of the patient's history that you must assess for a complex clinical problem. Oh boy, it's getting exciting. I hope you that are watching, all the aspiring physicians and resident physicians, that you're ready, because I think Dr. Jackson may be paging some people soon, because we're about to go to step 3. Let's go to the question and let's see what happens for the fundamentals of independent practice adaptation.
All right. So a 25-year-old woman comes into the physician because of a long history of crampy pelvic pain during her menses.
All right. So that's the same as the step 2 CK question, giving some
Right.
clinical sequelae. All right.
Right. So the pain consistently begins on the first day of her 5-day menstrual period and lasts for 24 hours. She rates the pain as a 10 out of 10 on a 10-point scale.
Still the same as the last clinical vignette, right?
Physical examinations, including a pelvic exam, shows no abnormalities. Exactly the same. The patient is started on naproxen.
Stop there. What do they do differently?
They started the management.
They've already started the management.
Right.
So you see, we're now in step 3. Management was already started on step 2.
Mm-hmm.
You see how that very subtle is? Step 2, we asked you what the management was. You told us naproxen. Now we told you we already started the management. Right.
Yep. So which of the following is the most likely mechanism by which this patient's condition occurs?
The mechanism of the patient's condition. Okay. So for the sake of discussion, we already know this is dysmenorrhea. I thought we asked the mechanism or pathogenesis of the condition on the step 1 question. Didn't we do that already?
Yeah.
So why are we doing it again in step 3 in the fundamentals of independent practice?
Because this is our so we want to assess, because I mean we've added more clinical complexity to the patient.
That is correct. You've added more clinical complexity to the patient.
So we want to see if the pathophysiology is still the same as
exactly. And step 3, as we said before, based on the focus and the goal, one of the goals is to understand more complex pathophysiology, which is still the basic science from step 1, but in an advanced clinical context. So, and if we look at these options in essence are all mechanisms of action of different diagnoses. Right. So we need to find the right mechanism of action for a diagnosis of dysmenorrhea. Right. So if you were to look at these, let's look at option A.
Increased leukotriene production within the myometrium. No.
Why is that?
It was trying to throw me off with the leukotrienes because that prostaglandins, leukotrienes, those, that's in that family, right?
All right.
And so, but that's not, it's not the leukotrienes that is causing that increased uterine contractions, which is causing the pain. It's the prostaglandins.
Got it. Right. Impeach it. A's out.
Impeach it. A is out. B, prostaglandin-induced uterine contractions and arteriolar vasospasm.
What do you think?
That sounds like it could be right. I mean, it's prostaglandins. I'm liking that. That tracks. Uterine contractions. That tracks. Arteriolar vasospasms. all of that
Yeah,
tracks.
because the prostaglandins are hitting the smooth muscle of that and causing them right to constrict inappropriately. So again, that is leading to the pain as well. That's giving us the ischemia.
Right.
Okay, so we'll hold on that one. Let's go to C.
Retrograde menstruation leading to endometrial seeding.
What's that?
So this is like endometriosis.
Oh, wrong diagnosis. Out.
Right.
Go to D.
Systemic upregulation of the hypothalamic pituitary ovarian axis.
What's
So
that?
this is getting into more of the hormonal aspect of a dysmenorrhea or amenorrhea process. So
You kind of referenced that earlier as part of potential differentials.
Right.
But again, as we said in the previous FS, once we determine that's the case, least amount of information with thinking and testing, that's not what's going on here. Out.
That's not what's going on, right?
We can immediately impeach it.
Immediately impeach it. And then E is the uterine ischemia caused by excessive estrogen-mediated vasoconstriction. So again, trying to mix up some of the
Exactly. Look at that. A and E.
Yeah.
Mama said a half truth is a whole lie. Starts out true. Yes, there's uterine ischemia, but it's not by estrogen. Look at that. Option A. Yes, there is something causing some impact on the myometrium, but it's not the leukotriene, it's the prostaglandins. Wow. Interesting. Okay. So that's an example of fundamentals of independent practice now under the USMLE Step 3. When we look at our pearls related to this, we can clearly see again what they're doing. They move the focus from just, yes, poor or what we call core pathophysiology to a more advanced pathophysiology in the presence of a clinical context that's more enriched and more things to consider, right? They did that. Then we also see that there is an increase of integration because they did almost what we call a second order question. You thought, hey, well, what do I treat it with? They told you what we're going to treat it with. They took care of that. So now we're moving to the next context. Well, what's really going on? And they asked you again the underlying more advanced pathophysiology. And then we like to talk about distractor complexity. There's some distractors in here because based on the description of the vignette and the options, there were some things that looked enticing but were inaccurate. And then there were other options that, yes, you know information about, but they don't answer the question because this is not those conditions. This is dysmenorrhea, right? So very, very interesting, again, how they frame it. Let's move on to your last one, the most complex, which would be advanced clinical medicine. And again, to make this advanced clinical medicine work, we're going to need to think about comprehensive patient management over time. Could be something related to that. We could be looking at your clinical decision making because it could be very difficult to determine the differential diagnosis, even though for the sake of our discussion, we know it's dysmenorrhea, but we're going to try to put other things in there that you have to address. So let's see how it stands up. USMLE Step 3, an adaptation for now advanced clinical medicine. Let's read the question.
So a 25-year-old woman comes to the physician for a follow-up visit regarding severe menstrual cramps. So
let's stop right there. What's different there? Severe, and now it's an additional follow-up, right? Okay, continue.
She has a 10-year history of crampy pelvic pain that...
Stop right there. What also is different?
So this is now over 10 years
A 10-year history. Advanced clinical medicine looks at long-term management. And we're getting other data that we have to synthesize. Advanced clinical medicine, step 3, also looks at gathering additional information. We can already see in the first couple of sentences, they're giving us more different information they gave us than before. Okay, let's continue.
So 10-year history of crampy pelvic pain that begins on the first day of her menses. She previously tried naproxen and ibuprofen.
Stop right there.
Yes.
Again, they're already telling us that they've tried the initial treatment.
Right.
Look at that. And we got a 10-year history. And this is happening every time the patient has their menses. And now it's severe, almost like an acute exacerbation of a chronic condition. And somebody needs to assess it because this has been going on for a long time. So what's going to be the longitudinal management? Because naproxen is not working. Ibuprofen is not working. What we're going to do, doc?
All right, let's keep reading.
Physicians, what are we going to do? Let's continue.
So no dice on naproxen or ibuprofen. So at maximum over-the-counter doses, without significant relief. She rates her current pain as 10 out of 10 and misses 2 days of work each month. That's significant. So she has no plans for pregnancy and is currently using barrier methods of contraception. Pelvic examination is unremarkable, and a recent pelvic ultrasound shows a normal uterus and adnexa. Which of the following is the most appropriate next step in management?
Interesting. So again, we see this little piece with the contraception. Why is that there?
The piece with the contraception is also is that distractor. So are we looking at an infectious process versus a physiological process, a pathophysiological process when it comes to the increase in the prostaglandins, or is this a pituitary hypothalamic hormonal type of issue?
Okay. So it says most appropriate next step in management. What's already been done already?
So we've already done a unremarkable pelvic exam, and then also the ultrasound was unremarkable as well.
And of course, you did the NSAIDs earlier, which was the first line. So all that's been done. So now we should be thinking about what would be the next part of the clinical algorithm, right? So let's go through the options and look at it, and you tell us what's going to be happening.
So A, diagnostic laparoscopy. So I would still impeach this option simply because still the pelvic exam and the ultrasound is unremarkable. So to me, even outside of an infectious process, if we're talking about other domains that could be causing pelvic pain during menses, so is there some type of like cyst or any type of anatomical issue that could be going on? By the pelvic exam and ultrasound being unremarkable, I would take A off because a laparoscopic exam would be a more invasive, escalated part of the algorithm.
Okay, so the saying goes, we're not at that level yet, based upon what's been presented to you.
Right.
What about the combined oral contraceptive pills?
So I would put that on the list. I would want to see what else is there, but with the ibuprofen not working and then the naproxen not working, so we had the first line, which is the NSAIDs. Those are not working. We then, followed up and did more workup with the pelvic exam and then the ultrasound. Still not seeing anything abnormal on those procedures. So the combined oral contraception would likely be the next step, being that the NSAIDs didn't work. So now we want to take a hormonal approach to pain management with dysmenorrhea.
So what do these hormones do? How do they actually work?
So when you're talking about estrogen, if you're talking about estrogen and progesterone as it pertains to the menstrual cycle, they have different phases, and
this is going back to the basic science. So in essence, you're going to be kind of thinning out the endometrium, so that would mitigate some of the contractile process and some of the discomfort that's occurring with it.
So the estrogen, which is growing that endometrial lining, and then the progesterone, which is going to then shed that endometrial lining. So
watch this. That's basic science from step 1 integrated into step 3.
Yeah.
Here we go again.
Right.
Which is why when we have an anchor of success on step 1, it helps you with step 2 CK and with step 3.
Right.
You never move away from the basic science. You will always be saved by basic science and its understanding because you can apply it to the clinical medicine. That's very interesting.
Right.
I love that option.
Yes.
Okay, so you're going to hold on to that one.
We'll hold on to that.
Okay.
So option C is prescribed scheduled high dose celecoxib. Celecoxib is I believe it's a COX inhibitor as well. because I know there's a Cox 1, Cox 2. I'm not necessarily sure which one this is.
But that's proxy for what the NSAIDs are doing then, right?
Yeah, it's already,
Right,
we've
so
already
it's always been
tried
tried.
2 NSAIDs
It's always
and
been
it's not
tried.
working. So
Because in essence, the NSAIDs, inhibit the prostaglandin synthesis, but the hormones that we're talking about back up in B, the estrogen and progesterone, they're going to, in essence, work by thinning out the endometrium where the prostaglandins would be synthesized, thereby decreasing the amount of prostaglandins again. It's
Right.
another way to get the same outcome.
Same outcome.
Interesting.
Right.
Wow, this basic science is something. Okay,
So
that's impeached. Let's go to D.
we're going to impeach that one. D is gonadotropin releasing hormone agonist therapy, so GnRH. So this is going to that hypothalamic pituitary axis domain.
Wrong mechanism
This
that's
is the
happening here,
wrong
right? That's not the mechanism
of the
that's causing this.
pathophysiology. Yeah.
So it's interesting because you brought this up in a couple of different ways, and see how they keep coming back at it
Right.
as a potential, consideration, and they find proxy language. I'll give you the mechanism. I may say it's this condition. They keep coming back to it. Isn't that interesting?
Right.
All right, let's go to option E.
So E, presumptive treatment with fluoxetine.
What's going on with that, psychiatrists? Why are we giving patients fluoxetine?
So this is premenstrual syndrome, so PMS or was it PMDS? I'll have to go back through those. But so when you're talking about the fluoxetine treatment, sometimes we're talking about giving these particular SSRIs as treatment for a more elevated dysmenorrhea. So when you're talking about PMS or the dysphoric version, so that's like the more escalated pain version of the within this continuum of dysmenorrhea. So when you're talking about presumptive treatment with fluoxetine, that's where that question is getting at. But again, the pain is 10 out of 10. This is a chronic situation. We're talking about a 10-year chronicity of this issue. But again, the pelvic exam is unremarkable. The pelvic ultrasound, and then the chronicity in terms of when the crampy pain is beginning. So it begins on the first day of her menses. And it's not talking about how this is lasting for a continuum of days throughout her cycle. Okay. So that if it's going based off of the first one of the first adaptations where it says it starts the pelvic pain begins on the first day of her menses and it kind of ends. I think we're not talking about a PMS situation.
All right. And then the other context is that even if you move toward least amount of information with thinking and testing skill, before you even move to fluoxetine, there was no discussion about having tried hormonal therapy yet.
Oh yeah, we can just cut it there. Yeah.
Once again, I'm not a doctor, but I play one on TV.
Right.
So least amount of information with thinking and testing says if I'm following the algorithm, we still try, if it's appropriate, what's next in the algorithm before we go to a more escalated advanced context.
You could have stopped me before I struggled through trying to.
But sometimes it's good, as you and I know, right, to talk it through, because right now, scholars, we're practicing also testing skill. We can have a lot of knowledge, understanding, but we put it together with testing strategy so we can be efficient in closing out the question because we have only 90 seconds. Isn't that something? We are slowing it down for the purpose of us working it together, but that's why we do that sometimes, because that's what actually happens when we're practicing. And once we learn through our error analysis, our discussion, oh, that's right, we didn't have to do that. You now encode that as a strategy and say, I always look at first what's next in the algorithm to consider, and I address that. And we address hormonal therapy as next and appropriate and therefore most likely, right? So you confident on that answer?
B.
All right.
100%.
And what's confident? Another 100. Ooh, you 100% on everything today. This is pretty impressive. Well, you're correct again. And if we look at our pearls on this one, again, what's happening? Look at the change in the question stem, right? And the vignette, it moved from, in essence, hey, what's the underlying issue, to next step in management, but after initial therapy had already been tried. That now is the key that we're moving into an advanced clinical medicine context. Initial therapy had already been tried. Then also consider the clinical realism that was occurring with this particular vignette, because you have all these failed first line treatments. So, and we got the timeline of this has been going on for 10 years. So now we know we're in a longer term management and trying to give the patient some relief and looking at an appropriate intervention to do that, which then gets to the complexity of your clinical decision making, because there are some things here we could do, but they're not appropriate for next in the algorithm to do, right? Right? They either are too invasive at this point, or it's not appropriate based on what we understand is the underlying issue going on with the patient.
Right.
Ooh, that's a lot.
Right. So,
But hold on to your seat, because we have another clinical concept to do the same thing again, because we know that's what you want.
I was going to say, well, I'm drained. So, have a good day, scholars. So,
Exactly. We
we
know
got
the
a second
scholars.
set, right.
That's right. We know the scholars appreciate you, but we always try to give them at least 2 exemplars. But what happens here is the exemplar has to go across 4 domains. Step 1, step 2 CK, step 3 FIP, and step 3 ACM, for you to appreciate how that's adapted over time, and how when we understand the form of how the question is going to be asked, we understand the focus and the goal of that particular exam, we can truly execute with strategy on these questions. You had a good breather? As you would say, do you need a mindfulness moment?
Oh, listen, I'm ready to go. You already
All
know.
right.
You're the dog.
Let's go to the next patient, and the next clinical concept we're going to focus on is the mumps virus. Right? So does the mumps virus, is it called the mumps virus, or does it have an actual name?
The mumps virus.
Or you can just call it the mumps virus.
Yeah, just call it the mumps virus. Let me see.
But the mumps,
is it para-influenza? Which one?
Para-influenza, that sounds reasonable to me. But again, I'm not a doctor. I just play one on TV.
Yeah, I'm not.
Well, guess what? We will only need to know that for step 1, where we might ask you the actual microbe that's causing the underlying pathogenic process. So let's see what happens.
All right. So jumping into this first one, a 19-year-old college freshman presents to the office with a 4-day history of tender, swollen glands. He has a 6-day history of fever, malaise, and decreased appetite. His temperature is 38.7 degrees Celsius, so 101.7 degrees Fahrenheit. Physical examination shows swelling of the parotid glands. Which of the following infectious agents is the most likely cause of these findings?
Well, look at that. So as we said now, for step 1, most times we're asking you the pathogenesis, right? Or we could ask you what we call baby diagnosis. We could say, oh, the patient has the mumps, but they gave us prox information that says basically it's the mumps. But we have to know what the infectious agent is. Now, fortunately for you, we know we're dealing with the mumps virus, so we know clearly the answer here is D. But don't worry, we're going to have fun. That's your warm up. And just to put your wonderful mind at rest, yes, you were correct. It is the paramyxovirus.
Oh.
I just had to have fun with you just to see.
Well, I said para-influenza, but
you said para-influenza. Well, I probably heard paramyxovirus, right? Right. So you know it was a para.
We'll say it was paramyx. I said
paramyxovirus. I'll still give you credit. It's paramyxovirus for this. But again, here it was nice because they just gave you the mumps virus, which is, of course, the common name. But if we put paramyxovirus there, then, you have to make some decisions. You may have been able to get it based on eliminating other options based on what you know about those options and whether or not they would fit the sequelae that was presented. So there's always more than one way to navigate a particular question. But this is a good example of an infectious disease question on step 1. We could just ask you what's the microbe, or we could ask you the pathogenesis of the microbe, which in essence is its virulence, its ability to create disease.
Now, this brings up a very interesting point about this continuum of the step series, because even with this, the format, we're talking about naming conventions and how being used to different naming conventions of the same disease process or path process can either hurt or harm you. Like if you're even talking about, so right here, mumps, but if you didn't know paramyxovirus, you might have gotten that question wrong.
Correct, if they switched it out.
Same
Exactly.
thing with like croup. You know, if you don't know laryngeal tracheal bronchitis, well, that's the other term for it, then you may get the question wrong, even if you're able to identify the different buzzwords or the different indicators within the vignette that's allowing you to know that this is croup. But if it gives you that second name convention that you may not be used to studying it that way, you may also
it could be a challenge. So sometimes the way we navigate that challenge is by also focusing on what we do know. And that means, let's just say, for example, option D, instead of saying mumps virus, it said paramyxovirus. But you didn't know that's what you were looking for, mumps, but you didn't know that was for mumps. Then you would say, well, is this representative of Epstein-Barr virus? Is this representative of hepatitis B virus, right? Is this representative of measles, right? Is this representative of rubella? And you wouldn't know what D is. So if you are confident that A, B, C, and E are not representative of what's presented in the vignette, especially with that key context of the swelling of the parotid glands, which is almost pathognomonic along with the other components, then the answer has to be D, the one you don't know based on testing skill. So that's another way that we can navigate sometimes if we're given another name for a condition that we did not recognize. Well, we go the other way. Can we impeach other options? So initially, we don't choose something we don't know. We can't always rule it out yet. We can only rule out something we don't know if we absolutely have another option that we believe, yes, this is the correct answer. Otherwise, you just put question mark by it and you try to either impeach or keep one of the other options as a possible answer, or impeach as not an option. And then by testing skill, if that one's still there, you can address it. It's got to be the answer. Isn't that interesting? Okay, let's see how we're going to make this a step 2 CK. So again, to make it a step 2 CK, what's going to happen?
We're going to add the clinical knowledge. We're assessing the clinical knowledge. So what is the additional piece in management possibly that we want to assess from this patient?
Okay, let's take a look at the vignette. Let's take a look at the adaptation.
Right. So we have a 19-year-old college freshman comes to the student health clinic because of a 4-day history of tender swelling under his jaw in front of his ears.
Stop right there. That has a great degree of specificity as compared to the other one of where the swelling is. Isn't that interesting? Okay.
Yeah, it's very interesting, especially given the answer choices in the first one, because you had EBV. So you thinking about what EBV can look like, it's kind of like a distractor.
Yes.
So he has a 6-day history of fever, malaise, and decreased appetite. Temperature 38.7 degrees Celsius, 101.7 Fahrenheit. Physical examination show bilateral tender and swelling of the parotid glands. He is unsure of his vaccination history. Which of the following is the most appropriate next step in management?
There it is, next step in management. So we know in step 2 CK, as you said, they gave us the other information about the swelling under his jaw and in front of his ears, now begins to bring up a possibility of a different diagnosis. Then they come back and give you a key feature, if you will, of mumps, which is the swelling of the parotid glands. But now, as you said, they worked on the other piece, see?
Right.
So we add other clinical sequelae for which you have to make a decision about what is the actual, what are you going to consider differential diagnosis versus definitive diagnosis before you can actually move to management. Okay, well, we know this is mumps. What are we going to do about it in terms of management?
Okay. So A, administration of the MMR vaccine. Uh, so it says that he's unsure of his vaccination history. I'll just leave that on the list for
Well, let's
right now.
stop there for a second. Whether he was unsure of his vaccination history or not, if I give him the vaccine right now, do you believe that's going to address the issue?
No, I just had a brain fart.
That is
Yeah.
correct. And you made that one easy for me.
Right,
That was
yes.
an easy point
Yeah,
for
so
me.
we will impeach right
So
off the
that's
bat.
like one you can immediately impeach.
Right,
That's not
yes,
going to
because giving the vaccine after the fact is not going to help.
So part of what we get to have fun with here in Facilitated Studios is that if I begin to work on the scholar, just like on the actual exam, we get cognitive fatigue.
Right,
We could have a miscue.
right.
Because I know you were like, wait a minute, as soon as I said, you're like, oh.
Yeah.
Very good. So we're impeaching A. Let's go to B.
Okay. B, application of warm and cold packs to the parotid area. So this is a possibility.
Why is that a possibility?
Well, a lot of times when you're talking about a disturbance with the parotid gland, a treatment would be that cold and hot compress, because sometimes it's not a mumps. Sometimes, a lot of times when we're seeing this like parotid stasis or the fluid is in older patients, a lot of times dehydration. And so then you can have some type of inflammation there. So a lot of times that first line,
that's first line just treated. Okay. Do we actually have another treatment for mumps?
Vaccination.
Before that.
A prophylaxis. Yeah.
Okay.
Mumps is.
That's interesting. Well, let's hold that thought, because right now we may or may not have to address that depending on what you see in the other options. Let's go to option C.
So C is incision and drainage of the parotid glands. Man. Just because it is the temperature is 101, you know, that would clue me into a possible infection. And then especially because it said it's tender and swelling of the bilateral tenderness and swelling of the glands. It could be a situation in which we want to have some type of incision and drainage. I would keep that for right now. Okay. D, intravenous acyclovir therapy. I'm impeaching.
Why?
This is not a viral herpes context.
It's not a retrovirus?
What, mumps? No.
Oh, I hope not.
Yeah, so
I'm just throwing it out there.
Yeah, so acyclovir.
With the acyclovir, okay.
Yeah, we're not talking about like a hepatitis or any.
All right,
any
so that's
type
a no.
of
That's
those.
impeached.
Yeah.
All right.
And then a prescription of a 10-day course of amoxicillin clavalinate. So
least amount of information with thinking and testing skill. What do we believe is the underlying issue? What do we believe is the infectious agent?
Paramyx virus.
Oh, it's a virus.
Yeah. Oh, you said that and it just ding. I mean, when you treat viruses, it's mostly supportive therapy.
Oh, mostly supportive therapy.
You're treating symptoms,
that's
fluid
the
hydration.
Phrase that pays. Yeah, that's why option B, in addition to what you said, is ideal. We're certainly not going to treat with antibiotic, but a lot of times it's supportive therapy. That's the key. So sometimes, remember, you gave us a great phrase. You said, use what you got to get what you want. Sometimes whatever the information we have will lead us to the correct option. We both are going to get 1 point, right? Whether you have more information, I have more information. If we get to the correct answer, we're both going to get 1 point. However, we want to be outstanding physicians, and we know we're going to be treating patients. So we always go back and say, oh yeah, I have to understand this process for my patients. This is primarily supportive care.
See, this is the reason why it's late. Because normally I would have been able, like, virus supportive therapy.
Correct.
That's why you was asking acyclovir.
That's right. That's why I
because
always have fun, because here at facilitated sessions, I'm trying to get an advantage because Dr. Jackson's pretty sharp. I can only get an advantage if we go late, because everybody begins to not see certain things, but he's hanging in there.
Right.
So you're going to stay with option B.
I'm going to stay with
as your
option
final
B.
answer, and that is the correct answer. And again, when we look at the pearls for this one, right, going from step 1 to step 2 CK, again, we see that they focus on the clinical management, right? That's a clear difference between step 1 and step 2. And notice how they ask it right in the question, what are we going to do for this patient? Right. We also see there's a understanding of the supportive care emphasis for certain types of viral infections, because we need to know as a core competency, given the antiviral or given the antibiotic is not going to change anything. We learned that from evidence-based medicine. So that's a key little pearl that comes up. There is the piece about the vaccination nuance that they put in this question, which was great when they said, as you said, he's unsure about his history. He's a college freshman and all that. These are all distractor clues, right, that we can consider. But, while the vaccine can prevent the mumps, it's not going to be used as a post-exposure treatment, right, scholars? So we know that. I only got that half point because it is getting a little late. and the way the brain works, it's like your brain did a replay of that and said, no, he didn't.
Right.
No, he did not do that to me. Because I'm always trying to have fun with Dr.
As soon as you said virus, I said, oh my gosh. Supportive care.
Right. So one of my fun things that I do with all scholars, and the ones who work with me over the years know, I will say things, and as you hear, you're like, wait a minute. It goes back to something you learned. I'm saying it like a key phrase.
Right.
Most times it connects. Right. Okay, let's move to step 3.
I got tight.
Notice though how you've kind of moved through the step 1 and step 2 CK context. Once you know the form, once you know the format, you're executing, which is good. I'm just trying to score a point and take advantage of any type of fatigue that might be setting in.
Okay.
I only got 2 more questions, so I think you're making a comeback. Exactly.
I'm tightening it up now. Okay.
So let's go to step 3 FIP, where we know now we're going to be looking at potentially more complex pathophysiology of the condition. We may be looking at a longer-term management. As you always like to say, it could be comorbidities. Let's see what goes on. Let's see what they do in the vignette.
So 19-year-old college freshman presents to student health clinic with a 4-day history of tender swelling under his jaw. He also has a 6-day history of fever, malaise, and decreased appetite. His temperature, 38.7 degrees Celsius, 101.7 degrees Fahrenheit. Physical examination shows bilateral parotid gland tenderness and swelling. He started on supportive care.
Stop right there. There we did step 2 CK. Don't you love that? Yeah. See, once you know the process, it's like you can pick up on it very quickly.
Right.
And because of that, if we were preparing for step 3, we're like, yes, we expect that because we know where this is going. So you already know that supportive care, whatever they should do with the initial treatment, they're not likely to ask you that. They're ready to move on to something else that's very important to appreciate, right? Okay. Now, it's possible, based on the other options, under a day 1 fundamentals input to practice, it's possible they could do it.
Right.
It's just not likely, right? So you're kind of looking and reading for, did they do anything yet? We see that. Okay, let's go to the question.
Which of the following is the most likely complication associated with this patient's condition?
Ooh, complication with the patient's condition. So we have to know the condition, and then you talked about this earlier. Sometimes the condition impacts another system, right, or it could be a different question. They might do this. There could be some other problem with the patient that impacts the chief complaint. In this case, it's whatever's happening with the chief complaint that condition is also impacting something else. Okay, so let's take a look at the options and see what's going on.
So acute glomerulonephritis. I'm going to impeach A. No, I don't. There's not a glomerulonephritis. There's not an acute renal issue.
Renal issue with this particular condition
as a sequelae of mumps.
Okay.
To my knowledge, I can't offhand. I don't think that acute glomerulonephritis is associated with mumps.
All right.
So I'm going to take that out. That's just something I strongly don't recall connecting to.
So
mumps.
sometimes what happens is that in the deep recesses of our brain, we're making no association. We can, if it's a very strong impression, we can trust that, impeach, and you move on, right? Sometimes we want to spend time, scholars, oh, let me just think that through and go through something else, and all of a sudden you get stuck because you can't remember all of the pathogenesis, but you had this very strong initial impression. Initially strike it.
Right.
If that impression is strong, because it still comes in the least amount of information with thinking and testing. You may not be able to give you the whole details about, but that impression is strong, I'm going to strike it.
Right.
And then if we have to recircle back because we strike everything, we'll do that. But that may not be the case. Let's go to option B.
Option B is aseptic meningitis. That could be a complication, especially with the inflammation of the parotid glands. It could cause a viral meningitis.
You're already in the head and neck region too, which is interesting. Okay.
Right.
All right, possible. All right.
C, chronic Sicca syndrome. I don't remember what that is.
Question mark. Let's see what happens. That's the question mark. So when we don't remember what something is, we can't impeach it, but now you have an option that's possible and an option that's question mark. So keep that in mind, scholars. If we were to impeach options D and E, and I don't know if we're going to do that yet, but this is illustration. If we impeach options D and E and you have something that's possible versus a question mark, you choose what's possible. You don't choose what's a question mark. Right? So that's how you handle this point. But we have to see because we don't know what you're going to do with D and E yet. So let's go to D.
Hepatic failure. That's out.
Any reason or just visceral response? No recollection of bumps having anything to do with hepatic failure and hepatic insult.
Yeah, visceral.
Okay.
Out. And then E, subacute sclerosing panencephalitis. That's absolutely out. Because that it's funny because I'm thinking about the sketchy micro sketch because rubella, measles, mumps, they was all in the same sketch. And so
okay, so you have a context for that.
Yeah.
And as I always say, once we have a context and we make an association, least amount of information, and boom, we can stop there. We don't have to keep playing with it.
This is a sequelae of another
something
infection.
Else.
Right.
Exactly. That's how you do it. So that leaves you then with B and C, B a possible and C question mark. Testing strategy says you choose the possible if it's possible versus a question mark.
Right.
So what are you going to do?
I'm going to go with B, aseptic meningitis, because I don't know what chronic Sicca syndrome is.
All right. Which confidence level on it?
For aseptic meningitis?
Yes.
I'd say about, I'd say 70%.
That's reasonable because you're making a connection to it, but you have this other thing you're not sure about. So you're like 70%. Well, it turns out you're correct once again, so you're batting 1,000 tonight, Dr. Jackson, which is very good. And you know, one of the fun things they could have put in here as an option would be probably orchitis, right? Because we know that mumps and can potentially impact in the males. The testes cause orchitis and potentially sterility.
So that's what I was thinking. Maybe A was trying to put a little red herring because it's in the part of the genital urinary system.
Okay, yes.
But that's why I was like, oh, you know, off the bat, I don't have an association between acute glomerulonephritis and mumps. But then I also wanted to take it off because I felt like it was a red herring for the orchitis type of context.
Exactly, which is something they typically know evidence-based medicine, which is a piece of step 3 they like to bring in. When they look at epidemiology, we look at the probabilities of certain types of conditions, and the aseptic meningitis and the orchitis, depending on the age and some other factors, you could see one or the other.
Right.
So it's interesting they didn't put both there because that could have been potentially a confound depending on how they set the construct up. Well, of course, it's an AME adaptation, so I guess that person was probably us. Okay, the us is me, myself, and I. What can I say?
Right.
Maybe I do know a little something, but I never know as much as Dr. Jackson. Let's point out again the pearls here, though. Again, we're underscoring how you can understand this process, right? The pearls are we went from a step 1 what is this condition? What's the infectious agent, right? It's basically mumps and it's a, paramyxovirus. To now we're in step 3 where we're getting you to focus on what are some of the other impacted, sequelae within the human body, other things that could be impacted because of this condition, right? So within another particular system, in this case, aseptic meningitis, we're also thinking about, again, we do have some key features like around epidemiology. We're a college dormitory, college-age students. So that's another close context to potentially discriminate toward
A bacterial
mumps.
meningitis,
Or a
or
bacterial meningitis.
because especially because it has a temperature. So one would think, oh, temperature, but then
Until we
didn't
get to the
give,
parotid glands.
yeah, till you get to the parotid glands, and then also
versus
some
nuchal rigidity.
neutral, exactly.
All
Right.
those little key contextual clues, right? So are there. So again, the step 3 is teasing that out, and then we have a little bit more integrated pathophysiology going on to actually appreciate how this condition could impact other systems within the body. Okay, last one. We're going to advanced clinical medicine. So we're expecting some, additional complexity with the sequelae, potentially with management. Let's see what happens.
All right. Same 19-year-old young buck, college freshman, presents to the student health clinic. 4-day history of tender swelling under his jaw. 6-day history of fever, malaise, and decreased appetite. He lives in a university dormitory. Temperature 38.7 Celsius, 101.7 Fahrenheit. Physical examination shows bilateral parotid gland tenderness and swelling. He has started on supportive care with ibuprofen and warm compresses.
Stop there. So we already know that we passed step 2 CK, right? Let's see what's going to make it advanced clinical medicine in a moment.
Which of the following is the most appropriate next step in the management of this patient?
Interesting. So we're still looking at advanced management for this patient. And when you glance at those options, I'll do something a little different here. When you glance at those options, can you subcategorize those options? Because I'm seeing different things being done.
I see medication management.
Thank you.
I see kind of like ethics, not so much ethics, but more of the management. So isolate the patient, public health
it's also
department.
public health prevention, which is a competency on step 3.
Exactly.
You're required to look at community health concerns.
Right.
Isn't that interesting? See how they work that in there?
Right.
Interesting. Okay.
So I'm seeing escalated workup with the urgent ultrasound.
There's your
the MMR.
There's your orchitis.
Yes, for orchitis. So urgent ultrasound to screen for orchitis. MMR vaccination, given all the students are in the dormitory.
So that's a 2-for-1. That's like a public health context and a medical intervention.
Right. And then this next one is chronic follow-up, or a follow-up over a longer period of time. And then another procedure. So basically a follow-up procedure.
So we got to figure out which one of these is appropriate.
Right.
As the next step.
Right.
And we've already done supportive care. So what would be the next thing we should do out of those categories? What should we do?
Okay, so I think first and foremost, you want to isolate the patient and notify the public health department. Mumps is a very infectious process, and so especially given the demographics given about this patient being in a college dormitory, just in close quarters with other contacts.
So that makes a lot of sense to isolate them. You're doing the supportive care, isolate them, let the public health department know. That would be like the very next thing before you could even move toward vaccinating other students in the dorms. You got to first isolate him.
Right, because A is asking is providing a therapy, which we already have said that this
supportive
is an aseptic or just a viral, supportive care type of situation. So A just would leave. Ultrasound.
C is like a major complication that would happen if he was experiencing symptoms related
Experiencing symptoms.
to the mumps, right?
Exactly.
Spreading. Okay.
But nothing in the clinical vignette gave any indication that this patient had any type of inflammation in their testes. So that's not something
That's
that we
out.
would need
And
to
then
work up.
E is the advanced context. You said that's like really right,
Yeah.
long
So
term.
schedule follow-up autogram in 2 weeks to screen for hearing loss. So um, I'm not necessarily sure where they're going with that, with the hearing loss. I'm not sure if
And we
if
wouldn't
this,
have to be, because
yeah.
that wouldn't be the next thing we would do. We would isolate them.
See, I get too much. I can have fun with this, and I want to dissect everything, but
Exactly.
you can't do that.
And the scholars are appreciating that. They're saying, "Wow, I
I'm talking
do
about
that
during the
too."
exam.
But that's why I say
That's
I
not
do
what
that
you
too
wanna do,
sometimes.
yeah.
Sometimes it's the least amount of information. I always say with thinking and testing, because again, what are we going to do next? We did supportive care. We need to isolate. We need to isolate, do the public health, and then everything falls after that. So after that, I can just start peach, because is there anything I would do before that in between the supportive care and isolating? Doesn't appear to be anything else to do based on what was in the vignette. This is, again, a great example of how we can take a core clinical concept, go across the 4 dimensions, if you will, of the Step 1 series. It's 4 because Step 3 has ACM and
FIP.
FIP. But again, just looking at the learning objective shift, we can see from Step 1, we went to the underlying basic science, to Step 3, in this particular case, looking at the vignette. Step 1, we asked about the pathogen. Here, we are clearly focused on how we're going to manage the patient, what should be done next. The clinical decision making is key here, because in your decision tree, after we do supportive care, hey, we need to isolate you and now report this to the public health department. Some of those other things are going to come, but that's the next thing to do. And we have to watch the distractors, because, again, in this one, they put the orchitis there because a lot of scholars remember that mumps, males, orchitis.
Right.
So that's very attractive.
pathognomonic.
But again, next appropriate step based on what's already done, which was supportive care. If we know the form, the format, we can execute. There it is.
So I think I'm batting at 100%.
You are correct.
I think I wanted to just add
that is correct response.
Before we end this.
That's right. We definitely want to confirm for our studio audience that you got 100% on all 8 questions. Again, going across the USMLE series. Congratulations, Dr. Jackson. That's why you are the AME physician. And so, we so proud of you and excited to have you to really help our scholars break down this process. And as you share with me all the time, and as many of my physician colleagues have shared with me, listen, you can have an MD, you start doing these questions, you have to get back into that process of the thinking mode for a standardized exam, because taking an exam in controlled settings is different than what you actually do in the real world clinical experience. We're trying to, in essence, mimic the situation and then control at certain points we have to answer, but it is different. And you have to think through the process. You have to have a strategy to go along with your knowledge and your thinking.
Well,
Dr. Jackson, that brings us to the close of the special
brings us to
edition.
the close. So we talked about the focus, how we should go into
Yes.
our dedicated study period. We talked about the form and the format and the blueprint of the exam and the different type of question choices. And then we talked about the execution, demonstrating practically how do we take all of that form and focus information and apply it to Step 1, Step 2 CK, and Step 3. FIP and ACM.
That's powerful.
So I'm a little drained, right?
Yes.
However, I did, as we close out, want to remind our audience again, if you are enjoying what we're doing here, please like and subscribe and share this video. If you know of a friend who is preparing for any of the STEP exams, this might be a good, useful playbook for them. So please share, like, and subscribe. This helps to grow the channel. And so for that, what do you want to say to close out?
I want to say
Because
that
I'm fried.
That's right. Great job again, Dr. Jackson. Scholars were so excited about your success and your journey to physicianship, and we look forward to seeing you in the next season of Facilitated Sessions. Take care.
Thank you for bringing it out.